Thanks, Keith. That was a really interesting talk. I also have to apologise because I haven't previously had the privilege of seeing Professor Kasai speak, so he's already mentioned most of the best things I'd hoped to mention. So I failed to be innovative on that account. So what I really want to do is I have 3 points that I'd like to bring up for discussion, and I think as we did before, I'll give, at the end of my short discussion, I'll give Katie in particular a chance to make her own points on those, and then I will open up for a wider discussion. So the first thing that I wanted to raise is an idea that comes up quite often in relation to discussions around genetic technology, especially in the healthcare setting, and this the idea of a geneticization thesis. So I've used a particular quote from a paper by Lippmann in 1991 to illustrate this, because I think it captures the core of geneticization thesis quite well. And Lippmann describes it as an ongoing process by which differences between individuals are reduced to their DNA codes, which with most physical and behavioural diseases defined at least in part as genetic in origin, and it refers as well to the processes by which interventions applying genetic technologies are adopted to manage problems of health. So I think you can see that there's an obvious relation to the type of discussion that we've just heard. And of course, geneticization thesis has been around for a while. It's an explanation from 1991. It has attracted some support, but it's also attracted a fair amount of criticism from various areas, for being overly deterministic, for not being supported by empirical evidence, and some authors have claimed that there's no evidence that there's any geneticization really happening outside of media discourse. So I want to introduce that, and later on, hopefully Keith can say a few words about where this particular the kind of research that she was talking about fits into that debate. But otherwise, I don't want to dwell on that too much. So the next point that I want to go on and think about is something I was struck by when I was reading through your presentation previously. And I was thinking a lot of the maneuvers that are taking place, the action that's taking place between naming and claiming, lumping and splitting, simplification and complication, seemed to me to be characterized, to be taking place in a kind of environment that was structured or characterized by a number of tensions. And I thought one of those tensions was in the sort of tension or between the ability to make diagnosis assuredly and with confidence and accuracy as part of the basis of medicine's professional authority, and not least in the way that that's an expectation that often that patients will have of going to the doctor. Between that and the kind of the uncertainty, the ambiguity of what we might call raw illness, which is presented and experienced by those patients turning up to be diagnosed. And a second set of tensions as well between the use of diagnostic categories as a basis for managing individual patients and patient cases, and the use of those same diagnostic categories, terminology, labels in research, which is looking at whole populations with a particular condition, even as we've seen that research may be redefining the boundaries of that condition at the same time. And then I thought I'd go a little bit further. I want to almost articulate this in a more basic way, saying it's it could be characterized by alternation between periods of certainty or attempts to create certainty and uncertainty, stabilization and instability. And I was going to then say, do we think medical uncertainty is something that we need to think about and address? And obviously that's already come up, so I'm not going to dwell overly on that, but I was wondering to what extent that's a helpful characterization. Is it useful? Is it relevant? And what are its limitations in thinking about taking this further? So the final thing that I was also thinking about was it's great to have that kind of insight to look at the actual practical processes that go into clinical judgment, classification, use of technology, but how do we take that and make it useful, and what can we do that is useful as well? There's not an obvious problem that we can go, that's it. If we just tweak that, everything will be okay. We can have translation, we can have clear diagnosis. And it's not even necessarily suggest that those are the ends that we should be looking to achieve. But what I did think, and I feel like is beyond the scope of my 15 minutes to answer that question in the completeness, but I did think it would be an important step to bear in mind the perspectives of some of those different groups that are identified in diagnostic, the use of tests for diagnosis more broadly. So on behalf of general practitioners, I like this quote from Christopher Dowrick, who is Professor of Primary Care at the University of Liverpool Hospital. He's also a practicing GP at the same time, and he wrote in an article on diagnosis, we general practitioners are mainly interested in the utility of diagnoses. We take a pragmatic approach. We welcome a diagnosis as an opportunity for reducing the complexities of the problems that patients present to us. We are more likely to make a diagnosis if we maybe understand a particular problem, particularly if we believe we have some means at our disposal to treat it. So I think it's a useful quote because it takes a more pragmatic approach to the idea of diagnostic categories as tools for managing uncertainty, for helping make decisions, for reaching practical outcomes, but not necessarily the focus on getting an absolutely correct diagnosis at that point that captures every symptom in a particular patient. Diagnostic categories also be very useful in ruling patients out of whole areas of potential illness and disease. So moving on from GPs, I also turned to Multiplex's paper, which we've already heard discussed, so I'm not going to dwell too much on the background of that, except to reiterate that the paper was largely an account of her own experiences being treated for cancer within a particular part of the UK health system. And again, in that paper, one of the things she wrote about that experience was that it was not the use of particular diagnostic tests and technologies, the screening and scanning and things that she found invasive or problematic on a personal level. It was actually the bit that she found most alienating and most difficult to deal with was the way that the patient record was used in her case, and particularly the way she felt that clinical judgments of the kind of we saw in Katie's presentation being made by clinical teams were made, as it were, behind closed doors, without any input from her. And I think that's really captured in this quote, and what she said was, in modern medicine, it's much more important for sociology to study the way in which images and records appear to create and control both medical practice and the patient's medical experience, and that's what actually counts. So I think that's also helpful in thinking about these overall process of diagnosis, about what things matter to who and in what ways they matter, as something to bear in mind when we're taking things forward. And I think what was interesting about some of Katie's work is that, in a sense, you got behind the scenes into some of those closed-door meetings, and the papers that you published in the talk you've just given gives us some of the insight into that. But at the same time, that's something then that patients can feel excluded from, certainly. I'm not suggesting it happens all the time everywhere, but certainly in some instances. I don't particularly have a great quote from researchers in the field, and I guess actually the presentation that's just preceded this has kind of dealt with that. But I did, as a final point, as something that I'd like to be taken forward into the general discussion. Like this quote from Moll and Elsman, and it's an interesting paper because it's co-authored by Anne-Marie Moll, who's a social scientist, and Bernard Elsman, who was a physician based in the Department of Surgery at the Dutch Teaching Hospital where this research was done. And one of their particular bit of research was about vascular disease, but that's not particularly relevant to this quote. What they recommended in the end of their paper was this, that diagnostic procedures that give more and more detail but don't have an effect on therapy may be an unnecessary burden, may even be a risk for the patient, and they moreover waste scarce resources. So to be rigorous, diagnostic techniques should be appropriate for what is done with the results. I think that's something especially to bear in mind as we move towards newer technologies like whole genome sequencing and sort of big data-driven science and classification-based approaches. So I'm going to end it there. If you want to have a chance to respond to the genetization.
Thanks, Michael. Brilliant. Kind of you. Yeah, I think genetization is one of those terms that it's great when we're searching for something to work on what's going on in genetics. So that term is coined, and if we're not careful, it becomes a bit of a millstone, but also it gives us something to rail against. And actually, yes, it's not so simple. That I think is, in terms of the syndrome being associated with a genetic mutation, a gene is significant, but only in a wider sense, in terms of it does have repercussions in all sorts of ways, and there are a number of genetic moments in the trajectory of the condition that have all sorts of unexpected consequences that aren't really about diagnosis, but they're also about understanding the syndrome, what it means, what is that child that has the syndrome. So it has a lot of unexpected consequences, the genetic moments in this condition, but what it doesn't do is fix the classification. And yes, you might find that non-specialists will still be using MECP2 and say that's Rett, but within the field, no, but they're still working on that alignment, but actually it's not working for them. And I think this is about what I'm trying to really look at is the complexities of the other social forces at play and how genetics is used and mobilised in all sorts of ways. Michael, in terms of the tensions around complexity, uncertainty, the trajectory and the utility, and take those two together, because I think that is quite important. Is this search for a way of creating certainty is very powerful, and we can all feel that power. So it would be lovely to have that way in which we can create that certainty, not just from the expertise embodied in the clinician, but in genetic tests, but also in things like guidelines, patient pathways, all those things that are routinely employed, particularly not just in clinics but in hospital settings, to try and get rid of the apparent human error, to get people into these pathways. But what you find, and I also find, in terms of the genetic syndrome, these diagnostic issues don't have any life or death problems for people. These children with Rett syndrome have Rett syndrome, or have problems. Having that label isn't going to change their life. There's no treatment that's going to be offered to them whether they have Rett syndrome or not. It's about managing their condition and their future. But in other fields I've looked at, such as cardiology, where there are also big drives in the hospital settings to define and reduce very complex conditions and symptoms into paper exercises. That's where it does have more life and death consequences. And that's some of the work I'm working on with colleagues in Bristol, looking at actually what are the things we can do in using ethnography to actually look at what are the processes going on in classification and diagnosis, how are people getting missed, why are people still dying when lots of money is going into rapid access clinics for chest pain. So actually, it's all about reducing the diagnostic process to some very fixed markers, but actually they don't help. So it's a really powerful drive in healthcare, and I suppose what we're trying to look at is ways in which we can look at that complexity and rather than black box it, actually explore it, and maybe we can help clinical teams and patient populations as well in that process. So thank you. Just a few thoughts.